Peter.
Hey, so Jeff, it's been a long time since we did the Eat, Move, Think podcast. It actually was 3 years ago.
It's our anniversary.
Yeah, it's our third anniversary. And last time it went over really, really well. It was triggered by the death of the actor Bozeman in the States. And that triggered a bunch of questions around screening for colon cancer. And so now it's 3 years later, lots more information. So we thought we would circle back and do another episode, especially with some changes that have happened here at Medcan. But maybe for the listeners that weren't with us 3 years ago, you can go through and just remind our listeners about your background and really what do you do here at Medcan?
So I'm the head of GI and endoscopy here at Medcan. I've been here for 14 years. Dr. Tim Devlin asked me to come 14 years ago, and I said, I don't know, I'm really busy. I don't have time for this. And since I've been here, I swear it's gone so quickly. It's really been great. But we run a program for endoscopy, like colonoscopies and gastroscopies. But I've been scoping almost 40 years. I've scoped over 40,000 colons. I've seen pretty much everything. The interesting thing for me is when I scope people and I see something, I always wonder, like, why? What happened there? Like, what happened at a cellular level there that formed that polyp or that cancer? Like, because it's not there. So I always wonder, like, what was going on with the DNA, the repair mechanism, and so on. The other thing I really find interesting is when I'm scoping, I can't tell age, I can't tell gender, I can't tell left-handed, right-handed, or ethnic basis. Everyone's colon pretty much looks the same. So it's sort of an interesting statement on humanity. But yeah, so I've been doing this a long time. So yeah, it's not. Today actually someone said it's not your first rodeo. I said actually I've never been to a rodeo, so I don't know. But it's not my first colonoscopy. I was the head of the Ontario GI Association, and I was asked to lead the Cancer Care Ontario clinical program for colon cancer screening across Ontario. And that's where I started to become interested and learn a lot about what's going on in Ontario at a global level, but then learning what's really important at a specific level, because it's really important to get your scope done. We're going to talk about that. So we have a program where we do endoscopy here, and we offer it for people who have certain guidelines, and that's what we're going to talk about.
Perfect. Yeah, no, it's great. And you've been a great leader for our whole GI program here at Medcan. And obviously, all of it is done at 150 York on York Street. It's been a successful program. So many of our clients have taken advantage of your care, and it's just been extraordinary. Maybe we can start by defining really the pathophysiology and the staging of colorectal cancer and, touching on maybe what are the signs and symptoms that folks need to be watching out for.
So before we talk about cancer, like what happens before cancer, because obviously you have a normal colon, and then sometimes you have a little bit more of a growth, and that's called a polyp, and that's called dysplasia. And they classify dysplasia from low grade to high grade. So just having a polyp itself, low grade dysplasia. But some of those polyps change, and you get what's called high grade dysplasia. It's not cancer, but it's getting there. And then you have full blown cancer. And the cancer can go starting early, like just in the lining. Then go through various levels. So the top level is just called A. Then we go to B, where it goes into the lining, but not through the muscle layer. If it goes through the muscle layer, it's C. And if it goes beyond that, it's called D. So those are sort of old-style, traditional way of describing how extensive it is. But then they also describe the type of cells, whether there's distant metastases. But that's really a way of looking at it, going from normal to cancer. It usually goes through that dysplastic phase. So when we're looking at your colon, yes, we're looking for cancer, but we're actually looking for those pre-cancer phases, those early and late dysplasia.
Mm-hmm. And then signs and symptoms that people need to watch out for?
Often there aren't symptoms, but if you are going to have symptoms, you might get things like bleeding. So you might see blood on the toilet paper or blood actually in the stool. That's a little bit more concerning, because sometimes blood on the surface of things is just something like from a hemorrhoid. But when it's mixed in, that's where you start to worry. And other things, there may just be a change in the way your bowel's functioning. You might be getting more constipated, or you may be getting some bloating. But sometimes it's very non-specific. And I've been disappointed and surprised where people who've actually had cancers have had like almost nothing in terms of symptomatology. So that's why before you have symptoms, it's a good idea just to be checked.
And I think one of the most, as a family doc, one of the most common symptoms that we find is fatigue. So people are like, I'm lethargic. I just haven't got that get up and go anymore. And we do, a typical sort of generic blood sample, and we see, wow, there's a little bit of anemia there. and then a little bit of iron deficiency anemia, and we find out that that is actually one of the indicators, because if you've got a cancer, it's just bleeding a very small amount. Maybe you don't even see it in the stool, but the first symptom is really fatigue, and your doctor might get this simple blood sample and say, wow, your hemoglobin's kind of down. We need to really be thinking, one of those first things that we're going to be checking is if you haven't had a colonoscopy, we need to look at that.
Exactly. That's probably the most common way we find colon cancer is a family doctor has had the symptom, sees that their blood is low and that there was some iron deficiency, and then we'll go on to find the cause of the iron deficiency, usually bleeding in the intestinal system, and it's often coming from the colon.
Yeah. So how prevalent is colorectal cancer in Canada, and compared to say 3 years ago when we were talking last? Are we seeing changes over time?
Well, there's good news and bad news. I would say, what do you want to hear first? The good news is colon cancer is dropping a little bit. The bad news is it's still the number 3 cause of cancer in Canada. Number 1 is lung. Number 2 is prostate if you're a guy, or 2 breast cancer for women. But number 3 for both men and women is still colon cancer. So it's still prevalent. Over the age of 50, it's starting to drop a little bit, not a lot, but a little bit. And we're seeing that across Europe and North America. The problem is under the age of 50, it's rising, not a lot, but a little bit. And that's consistently being shown also in Europe and North America. We don't know why. We like to think, the rates are dropping because we're testing people over the age of 50, and maybe that's true. Maybe it's lifestyle changes, but all I can say is it is dropping a little bit, and that's a good thing over 50, but under 50, it's rising a little bit.
Yeah, and so in terms of screening, is that weighed in? Like over the last, say, 20 years, has screening weighed in on the prevalence, the rates?
Well, it's interesting. When you and I started, we weren't screening for colon cancer. We just did what's called opportunistic testing. Someone had symptoms or they name it, you need a test. So over the last 20 years, it's become clear that if you screen, it will be effective and colon cancer rates will drop. And so screening has been shown to be effective. Now, why do we start at age 50 in most places? That's because if you look at colon cancer rates, they start to be high over the age of 60. So it's thought, we think in terms of years of 5 or 10 numbers. So let's start at age 50. So that's why age 50 was started. It wasn't 50.2 or 50.3. It was just a number that they came up with. And so that was the number that we started. The problem is, like I said, when I started working for Cancer Care Ontario and I started working here, Medcan says, we believe in early screening. And I went, really, the rates start at age 50. So when I started looking at our numbers in Ontario, what I was shocked was with Cancer Care, with our numbers, 8.8% of our cases for men were under the age of 50, which meant that not only did we find it even started before the age of 50. So that's when I became much more open to the idea that maybe we should be screening earlier than the age of 50. The American Cancer Society was one of the first groups that actually came out and said the rates under the age of 50 are starting to rise. We suggest screening under the age of 50, and that was picked up by all the American guidelines as well. So now in the US, the guidelines are starting at age 45. Again, we use that number 5. Why not 46? Why not 44? They just said, let's start it at 45. Here in Canada and provincially, we have not yet changed, but I think it's just a matter of time because it makes sense. We know that with screening over the age of 50 makes sense, and we know the rates are rising under the age of 45. So we here at Medcan have said, you know what? If you want to be screened under the age of 50, we will do that for you. We will do it in a standard professional way, and you can be screened if you want to. Bearing in mind, that's not a Canadian standard, but it's an American standard. It's probably going to change. We just think we're going to be ahead of the wave.
Yeah, like other things, we're leading edge.
Right.
We want to be ahead of that curve and providing the best quality care that we possibly can. And when we're saying screening, we're saying colonoscopy. And I know you feel very strongly there's other screening methodologies out there. Maybe you can just kind of go through, we have FIT, we've got versus colonoscopy.
Right.
Like, what are the things that are out there?
So there are other ways of screening. Everyone was hoping, is there a blood test for colon cancer? It turns out there isn't really a good blood test for screening. You can get a blood test that will pick up cancer markers, but by the time that's positive, you're sort of screwed. So they're looking for what can we do to people who are healthy to pick up things. So there are stool tests that we originally started with the FOBT test, which was a test for iron or heme in the blood, and that turned out to be okay, but our false rate, meaning our false negative rate we missed was 49%. So half the times we missed colon cancer. And family doctors got to know that because they would have tests that came back negative and patients had cancer, and they went, okay, I don't trust this. So now there's a test called FIT, which is a test for blood, which is better. The only problem is not every cancer bleeds. So we know now, multiple studies have shown that the FIT test will miss 20% of cases of colon cancer. That means if you've got colon cancer and you go for the FIT test, it will report normal 20% of the time. So that's not great. It's not bad.
When cancer's actually
when
there.
cancer's actually there. But if you're looking to screen a whole province with millions of people and all over the place where it's hard to do colonoscopy, doing a FIT test does make sense. It's a valid test. There are better tests, but at least you can offer it to everyone. It's easy, but it misses about 20%, which brings us up to colonoscopy. Now, colonoscopy is not perfect either. We'll miss 1 or 2% of cases too. But I think it's better than missing 20%. So my feeling is not only is colonoscopy more accurate, but it's going to pick up the early cases. You're going to find it in a polyp stage, so it's going to prevent colon cancer. So if you want something preventive, do the colonoscopy. If you just want to pick up something, do the stool test. So most of us are into preventive stuff, so we'll do the colonoscopy because we can pick up polyps, snip them off, and take you back to normal.
Yeah, I think that's an important takeaway where it's diagnostic and therapeutic at the same time, and you're picking up things before it's actually cancer, whereas the FIT, if it's bleeding, it's probably cancer.
Right.
And unfortunately, cheap, easy to do, but again, doesn't line up really with where we want to be from a Medcan. And for our clients, like this is all about prevention and getting things early so you don't have to go through anything radical. You know, that something has spread to a class D or it's metastasized to a different part of the body and you're going through chemo and radiation and surgery and having your bowel taken out. And it's pretty horrific at that other end of the spectrum. So, you know, going upstream as far as we can, getting these screenings done. And, you know, the colonoscopy, like you said, it's you're eyeballing the colon.
Yeah. I mean, for us, the worst thing is when, you know, we actually find a cancer and, you know, it's like, where have we failed this person? You know, and it's invariably because the person hasn't been screened before. It's like a 60 or 70-year-old person never been screened. Or you'll hear in the community, you know, my cousin or my brother or my friend had cancer, they were never screened. That's when they show up for screening. So my advice to people is get screened, come early, and get tested.
Well, and I think the other thing about the FIT too is it can give you a false sense of reassurance, right? Hey, I'm normal, when in fact you were in that false negative category. And so you're like, I'm good. Like, another 5 years. And then that 5 years, you've got a fulminant cancer that's grown because you believe that test.
The other funny thing is how often you need a FIT test. So the best FIT testing is done every year. In Ontario, they do it every 2 years. So you're still going to miss out. And then it's still not the most accurate. So it's something. If you want the most minimum type of screening, do the FIT test. If you want there is better testing out there, like I said, such as colonoscopy.
Yeah. So again, there's sort of inexpensive, not the best, relatively
cheap and easy, not that accurate.
Right.
Okay.
Yeah. Versus what we can do here, and again, we're on site. We're doing this every week that goes by. You're picking up things like whether it's pre-cancer, cancer, that's happening basically on a weekly basis. So Jeff, what are the most common questions that you sometimes get asked from patients? During
the procedure, we get asked very common questions because people want to know, what does a polyp look like? And sometimes we'll say, that's what a polyp looks like. You see that thing we're looking at the screen?
That's it.
But it looks like a little mushroom or a little strawberry if there's a vascular supply. People want to know how long their colon is. And actually, if you stretch out the colon, it's actually about 6 feet. So that gets people a little freaked out sometimes. But it's all like an accordion, so it's all sort of shortened. And that's what we do. We actually shorten the colon on the scope because the colonoscope's not 6 feet long. They want to know what cancer looks like. Is that a cancer? And of course, that's what sometimes when we actually see that, like all the fun part stops. That discussion sort of becomes less fun. But it's not that common. We're going to see a colon cancer maybe 1 in 1,000, whereas polyps we're going to see about 20% of the time. So it's common to see a polyp. And we try to explain to people most polyps are benign. And I call them baby polyps. So we say, and now we're sending them to heaven. They're all gone. You know, they leave. And once we take them out. And in terms of what else do people ask? They want to know, actually what we do, it's interesting. We go beyond the colon. What we do is we actually go into the upper intestine. And the reason we do that is to make sure that we got to the very end. So we go beyond the colon into the terminal ileum, the end of the small bowel. And we take pictures. We document it. It's one of our quality control things because we have to make sure that we get there. And that's one of the things that we're tested on. Did we actually get to the colon? Because if you don't get to the end of the colon, it means you've missed some things. So we show people what their upper intestine looks like as well.
Awesome. And what about risks for, do people ever ask about the risks of colonoscopy?
Not during the test, surprisingly.
Good.
But before the test, we tell them the risks are, for example, like a perforation can occur in about 1 in 1,000 or 1 in 2,000 cases. We have never had a colonoscopy perforation at Medcan. We've got really experienced doctors. But it can occur. That's one of the risks. I think some of the other risks are people can get a little dehydrated. That's why we like giving intravenous fluids there. Some people get a little nauseous, maybe from some of the medication that we may give them. In terms of the other risks, I guess.
Yeah, really perforation is
the main risk.
Really
Yeah.
Yeah. And I guess just to underline what you already had suggested, like Medcan, our point of view on this is age 45. As to put a point,
Right.
a fine point on it, as opposed to age 50, which would be the more the standard treatments. And we're even at 45. We're probably missing a percentage people there, right? There's people under 45 that are going to be positive as well.
Yeah. So the question is, where do you really start? So there's ongoing studies now. And we're starting at age 45 here because we think it makes sense and it fits with standards as it progresses. So we're not going to wait till Ontario changes. And I would, like nearly all my medical colleagues, they're not waiting. So they get screened before 50.
So that should say
something. That tells you something.
right there. Yeah. Maybe a quick word on family history as well, because that is one of those things that we really, as part of a history, we want to know, hey, if somebody's got some colon cancer in the family, what does that do in terms of getting them in a little sooner, the risk of them having cancer at a younger age?
So let's talk about that. The overall risk of getting colon cancer lifetime is about 5%, meaning you have a 1 in 20 chance lifetime of getting colon cancer. Now, if one family member under the age of 65 has had colon cancer, your chance goes from 5% to 10%. If both parents have had it, your chance goes up to 20%. So it goes from 5% to 10 to 20 if both parents have it. So again, the risk, there is a genetic risk, but it also depends on the age of the person. If your family members, your parent had it at the age of 80 or 85, don't worry, you're not as high risk. So we do this sort of risk classification. Did you have colon cancer before? Did your parents have colon cancer? What's called first degree. Now, we also look at second degree relatives as well. Were there cousins? And how many cousins? So you have 2 secondary cousins in 2 generations, your risk goes up as well. So it's sort of like a deck of cards. How many cards are you in there to increase your risk of getting colon cancer? And then there are some unusual familial colon polyp cases. There's something called familial adenosis polyposis, where you just get a lot of polyps that you're born with and you're going to get colon cancer. Those are people who are usually picked up early on and all the family members get screened. But that's an unusual form of colon cancer.
One of the more rare ones that are out there. And how about, so that's a risk. Any other risks for colon cancer that anybody might have, in addition to picking bad parents?
Pick good parents. There are some lifestyle issues. I mean, we know obesity, smoking, eating certain foods like nitrosamines, processed foods will increase your risk. The surprising issue is fiber, because we keep pushing fiber as being good for me. It turns out the more fiber you eat, the more polyps you're going to get, which is sort of surprising. And the necessarily lowering your colon cancer rate with fiber actually hasn't necessarily shown to be all that strong. So I still push fiber. You'll feel better with fiber, but ultimately you still got to be screened. But I think the reversible things you can do, not smoke, keep your weight down, be active. Activity is also an important issue that's been shown in multiple studies. And family, pick your parents, right?
Yeah. So eating and moving, just part of the eat, move, think triad.
Right. Well, the other thing is, what about moving? What about bowel movements? Which is interesting because people think, oh, if I get constipated, I'm going to have a high risk of colon cancer. Oh, I should have cleanses. It turns out, actually, it's not related to how often you're going to the bathroom. Like if you go 4 times a day, it doesn't mean that your colon cancer rates are less. So that's a bit of a misconception that things are building up in your colon. And that you have
toxins are building up and that sort of thing.
No.
So those cleanses, there's really no science behind that?
No, people feel better when they get sort of get empty, but like the next day you're like back to normal. So I don't quite get it, but there's no science behind it, but you're not going to be healthier if you have a colonic cleanse. I think you will be healthier if you have a colonic cleanse and have a colonoscopy and someone checks you, but and then we won't bother you. If everything's good, the intervals are about 5 or 10 years depending on what we find.
Perfect. Yeah, I was actually going to go there. I think one of the advantages of Medcan over maybe other sites is actually the prep. And that's the one thing that people are like, oh my gosh, like this is no fun. In the old days, having to drink like a gallon of salt water, no, I can't do that. So maybe you can go through the prep, because I've had my colonoscopy here and it was really easy. And I like the idea that it's just your cleanse before you have your colonoscopy.
So it's changed. First of all, people couldn't stand it, and it was hard to take. So now we have these 3 packets, one at 6 o'clock, one at 10 o'clock, and then one about 2 o'clock the next morning. And that's called the same-day prep. And that really does empty your colon. And they give you some fruit flavored sachets, and it actually doesn't taste that bad. Actually, I found it tasted pretty good. But it does work without the big volume of prep that people took before. So there is better tasting stuff, less volume, easier to take, and it's really effective. So the stuff is way better than what we had years ago. And of course, the better the prep, the better I can see, and I can give you more accurate tests. So, and what's really interesting, when people are watching their colonoscopy, they're sort of pretty amazed going how clear it looks and how good it looks.
Yeah, pink is good.
Pink is good.
Yeah.
Blood vessels are good, folds they see. Yeah. It's pretty cool.
Yeah, no, the prep, again, was that big barrier. That's a psychological, and I think people still think that, and many centers, they are still using these old preps. And just that little packet in 8 ounces of water, 3 8 ounces of water. And yep, you're going to be going to the bathroom overnight, but you're ready the next morning. You come in and everything is clean as a whistle.
Yeah, the interesting thing is after people take the prep, you'd think they'd be really hungry. It does something funny. It's sort of, people aren't hungry. They're thirsty, and afterwards we make sure people get some IV fluids and some liquids. But after that, all the weight that you sort of lose, unfortunately, you're going to gain it right back. So within about a day or two, you're back to normal.
Yeah, perfect. Well, that's a great discussion. I mean, just in terms of final takeaways, is there anything kind of big takeaway for the listeners?
I would say don't be that person. Don't be that person that found out they had colon cancer because they weren't screened. It's easy. And in your life, I can tell you, every person who's listening to this is going to hear about someone who's had colon cancer. And invariably, that person wasn't be screened. So be screened. Don't be that person.
Excellent. Well, thanks for your time. Thanks for your expertise. This has been another great, again, it's our 3rd anniversary. We won't wait 3 years to do this again. I'm sure there's been lots more developments coming along. So thanks for your time.
Thanks for having me, Peter.